This is Daniel Lenahan, immediate past president of the International Cardio-Oncology Society, and I'll be summarizing our amyloidosis webinar series. The first webinar in our series was, who should I be testing for amyloidosis? I would encourage you to access the full webinar where more of these details are highlighted. What is amyloidosis? Well, it's a situation where a normal protein is produced and develops into a beta-pleated sheet structure, which binds together and ultimately forms an amyloidosis fibril. And when this fibril is formed, it then deposits in organs and tissues. And this is really the pathologic condition that is of significant concern when the fibril deposits in the tissues. There are many different types of amyloid proteins associated with human disease. Some of them, or most of them, are listed here, but the most important are AL, or immunoglobulin light chain amyloidosis, or transthyretin, which is transthyretin amyloidosis, or ATTR. The rest are very rare and should be considered in selected cases, but for the most part, more than 95% of all cases of amyloidosis are associated with either AL or ATTR. So in terms of clinical presentation, especially if you're talking about a hereditary amyloidosis, in the United States, the two most common mutations are V122I, which is estimated to be in 3 to 4% of African Americans, where of those that have disease, many of them, a substantial majority, 95% or more, have cardiac manifestations, whereas only about 50% have neurologic manifestations. Another important variant in the United States is the Irish or Appalachian variant, T60A. And again, most of those have significant cardiac manifestations, but a higher percentage have neurologic, especially autonomic dysfunction and gastrointestinal abnormalities. The most common mutation in Europe and Japan is V30M, and this presents almost always with substantial neurologic manifestations. So the early form may not have much cardiovascular manifestations, but later on it does develop in that way. So you can see, depending on the mutation, the disease may be manifested in different ways. In terms of wild type ATTR, this is a condition that does not have a mutation associated with it. How does this present? Well, classically, this presents with heart failure, and that could include atrial fibrillation or flutter. And there may be reasons for patients to get a pacemaker over the course of history. And so it's not uncommon that there would be the need for a device as part of the management of underlying cardiovascular disease. In addition, they frequently have carpal tunnel syndrome and lumbar spinal stenosis. Now, in terms of hereditary ATTR, the presentation of neuropathy I just pointed out depends on the mutation, but that is an important component of hereditary ATTR. And with that, orthostatic hypotension becomes a very major condition that has to be dealt with. Additionally, there are substantial gastrointestinal manifestations highlighted as early satiety and unintentional weight loss. And then there are a number of other conditions that may be the initial presentation of amyloidosis, including other abnormalities such as erectile dysfunction or sweating abnormalities. In terms of AL, again, heart failure is a major manifestation of AL cardiac amyloidosis. The other condition that's an important problem is nephrotic syndrome or proteinuria. So the kidneys are frequently affected by AL amyloidosis. And again, orthostatic hypotension may be a very important problem. Frequently, there are issues with unintentional weight loss, macroglossia, horn and large tongue, and then raccoon eyes, which is shown here as periorbital ecchymoses. And that is sometimes initial presentation for AL amyloidosis. And then in terms of red flag findings, so things that show up in clinical medicine that you really can't ignore, this is the point of the red flag designation. So if you have heart failure with unexplained left ventricular hypertrophy, if you are intolerant to typical medicines that we use for heart failure, if you have low gradient aortic stenosis or hypertrophic cardiomyopathy, and then if you have a family history of sudden cardiac death or apical sparing seen on imaging, these are all important cardiac manifestations. The renal manifestations include, and in particular, would involve unexplained proteinuria. And then the orthopedic issues we've talked about, bilateral carpal tunnel syndrome should make you very suspicious, lumbar spinal stenosis, and then biceps tendon rupture are also important findings. Neurologically, unexplained peripheral neuropathy, orthostatic hypotension, or autonomic dysfunction are all very important signs and symptoms of cardiac amyloidosis. In terms of the diagnostic algorithm, this is quite complex, and this algorithm is quite good in terms of simplifying it. But the two boxes in red are to be emphasized. Number one, whenever you're suspicious of amyloidosis, you really need to screen for the presence of a monoclonal protein by ordering certain tests that are highlighted here. And then if those tests are negative or normal, then bone scintigraphy is a good next step. Whereas if you have clear evidence of cardiac uptake on a PYP scan or other form of scintigraphy, that this can be highly predictive of cardiac amyloidosis. I would emphasize that anybody who you're suspicious of ATTR, you need to do genetic testing to make sure they don't have a mutation. And then in terms of general screening, important caveats for the use of bone scintigraphy. The first and foremost principle is that you need to exclude AL by these laboratory testings that have been highlighted before. And then you really must use SPECT imaging so that you can exclude blood pooling in the cardiac structure as a false positive. You really need to see cardiac uptake of the scintigraphy in the muscle itself. And then in terms of how to interpret free light chain values, this was highlighted in this webinar, is quite an important principle. And I think that the biggest thing is there are a few conditions that may cause a mild abnormality in your serum free light chain value. And that looking at the ratio and making sure that there is a monoclonal production of a protein is kind of the essential points.
Welcome to the second lecture in our online module entitled Cardiac Amyloidosis, Is it a Zebra or a Horse? My name is Katie Zhang, and I'm a cardiologist at Washington University in St. Louis, and today I will be discussing cardiac imaging pearls as it applies to the diagnosis and management of cardiac amyloidosis. This is meant to be a brief introductory lecture, and you can access the full-length lecture online at the France Foundation website. All right, so now let's dive into the talk. When I think of the diagnostic and management continuum for cardiac amyloidosis, the general process can be broken up into four components. First, we must suspect amyloidosis, and then we can diagnose amyloidosis. Next, we must confirm the amyloidosis subtype, and then from there, we can move on to treat amyloidosis. Cardiac imaging plays a critical role in these first two steps of the pathway, raising initial suspicion for the diagnosis and then helping to make the diagnosis in many cases. Cardiac imaging also plays a smaller role in confirming the amyloidosis subtype and monitoring treatment response, as we will discuss shortly. With regards to raising initial suspicion for cardiac amyloidosis, cardiac imaging plays a critical role. There are a number of findings on electrocardiography that are classic for cardiac amyloidosis, although these generally have limited sensitivity and specificity when used in isolation. These include low voltage QRS, particularly in the limb leads, pseudoinfarct pattern, seen here in leads V1 through V3, atrioventricular block, either first, second, or third degree, and relative low QRS voltage in the setting of LV hypertrophy. Echocardiography can also be very helpful to raise initial suspicion for the diagnosis, specifically increased LV and RV wall thickness with diastolic dysfunction. Apical sparing of longitudinal strain has also been associated with cardiac amyloidosis, though the sensitivity and specificity of this finding is only about 70%. Cardiac MRI can also be a very useful tool to confirm the diagnosis of cardiac amyloidosis. Traditionally, late gadolinium enhancement, or LGE, was the only diagnostic tool available. Diffuse subendocardial gadolinium enhancement is a classic finding of cardiac amyloidosis, though other LGE patterns can also be seen with lower sensitivity and specificity. More recently, elevated T1 relaxation times, as well as increased extracellular volumes, have emerged as additional techniques that have excellent diagnostic utility in select patient populations. Clinically, cardiac MRI is useful to confirm cardiac amyloidosis in patients with established amyloidosis by tissue biopsy of another organ. Current cardiac MRI techniques are not able to distinguish between different subtypes of cardiac amyloidosis. Now, in addition to having utility for diagnosis of cardiac amyloidosis, cardiac MRI has also demonstrated utility for prognosis and evaluation of treatment response, particularly in patients with light chain amyloidosis. On the left, we see data from Dr. Mariana Fontana's group demonstrating the prognostic utility of baseline extracellular volume by cardiac MRI for clinical outcomes in patients with ATTR and AL cardiac amyloidosis. On the right is an example of a patient with light chain amyloidosis who underwent serial cardiac MRI studies at baseline and after treatment of 6 months and 1 year while on AL therapy. And this patient was found to have regression of cardiac amyloid involvement by T1, late gadolinium enhancement, and extracellular volume measurement techniques. Finally, nuclear imaging has both established and emerging roles in the management of cardiac amyloidosis. Technetium-labeled nuclear imaging using DPD in Europe or PYP in the US plays a key role in non-invasive diagnosis of transthyretin cardiac amyloidosis. In a large multi-center study, technetium nuclear imaging was found to be highly sensitive and specific for transthyretin cardiac amyloidosis. Importantly, light chain amyloidosis must be excluded and SPECT imaging must be utilized in order to avoid false positive test results. Several other nuclear imaging modalities may also be helpful when evaluating patients with amyloidosis. 123I serum amyloid P has demonstrated utility for assessing the extent of non-cardiac organ involvement in patients with amyloidosis. Additionally, 18F florbetapir is currently being studied as an agent which may distinguish light chain from transthyretin cardiac amyloidosis. In summary, cardiac imaging plays a key role in raising diagnostic suspicion for amyloidosis. Echo, cardiac MRI, and nuclear imaging each have unique strengths, and they complement tissue biopsy for diagnosis of cardiac amyloidosis. Cardiac imaging, specifically MRI and nuclear imaging, may also play a role in assessing prognosis and treatment response, with specific roles that continue to evolve with ongoing research.
And I now present a summary of the fourth in our series of webinars. I'm Daniel Lenahan, the immediate past president of the International Cardio-Oncology Society, and I welcome all of you. I would encourage you to please view the previous webinars and also to view this one in its complete form, which I will show you the slides summarizing the complete webinar. This is entitled Cardiac Amyloidosis, Treatment of Cardiac Amyloidosis. In terms of the treatments of ATTR amyloidosis, there are a number of targets of therapy. So in this webinar, Dr. Richard Chang presents a very detailed and excellent review of these topics. So the first is the suppression of TTR synthesis, and these are medications that are considered RNA silencers, and they include patisiran and inotersen, and then there's newly developing therapy that is based on CRISPR technology. But the whole purpose of these therapies are to suppress the TTR synthesis. The next major class of therapies includes tetramer stabilization, and there are selective agents. The only one currently approved by the FDA in the United States is tafamidis. There is a newly developing drug called AG10, where the other name is acoramidis, and that is felt to be similar in mechanism to tafamidis. And then there are non-selective agents that are utilized but not approved by the FDA, and that includes diflunisal. Other targets of therapy for TTR include the amyloid degradation. And so basically we're trying to block the deposition of fibrils or extract them from the tissues, and that could include a drug called PRX004, which is under development, and the anti-SAP antibodies, as well as the antifibril antibodies, of which PRX is one of the options. Nonetheless, these are aimed at the actual fibril, and these drugs are under development. In terms of available ATTR medications in the United States as of November 2021 for ATTR cardiomyopathy, whether it's wild type or hereditary, the only indicated medication is tafamidis, and then diflunisal is an off-label usage. In terms of hereditary TTR, where neuropathy is present, the options include patisiran, inotersen, and then diflunisal continues to be an off-label option. If you have the presence of cardiomyopathy and neuropathy, your choices include tafamidis, patisiran, or inotersen, and again, diflunisal. If you only have cardiomyopathy, then the only option at this point is tafamidis. So there are many trials happening right now to try to improve and expand the indications for these drugs in a broader treatment of amyloidosis, but those are still under investigation at this point. In terms of take-home points, there are two main strategies proven to be effective for treating ATTR amyloidosis. Number one is silencing the production of TTR using patisiran or inotersen, and then stabilizing the TTR protein with tafamidis. The new CRISPR technology is certainly promising, but is a very small data set at this point. There are many emergent therapies for amyloid degraders and extractors that we expect to see some very encouraging findings quite soon. In terms of the treatment of AL amyloidosis, Dr. Weckelatcher presented a beautiful overview of the treatment of AL. And this slide right here just highlights all of the different drugs that have been investigated. At this moment, or at least in the United States, the only one that is approved by the FDA for the treatment of AL amyloidosis is daratumumab-based regimen. All these others have been looked at different levels, but are not currently approved for the treatment of AL. And the daratumumab indication is based on the Andromeda study, which is highlighted here. And you see the really significant alteration in all-cause mortality without progression in the patients that received a daratumumab-based regimen. And this was compared to the standard regimen, CyBorD, which includes multiple drugs. So this was really groundbreaking therapy and truly life-saving, and now is considered the standard of care, at least in the United States. When we think about cardiac amyloidosis in particular, other than treating the underlying amyloidosis, in the case of ATTR, treating it with anti-ATTR therapies, or in the case of AL, treating with anti-AL based therapies, there's still the cardiac disease itself. How do we manage that? Well, there are some very important principles in terms of managing specifically heart failure and rhythm disturbances in patients with cardiac amyloidosis. So first is diuretics are going to be your mainstay, and their patients frequently have large amounts of edema and ascites. And if they happen to have hypoalbuminemia, this would also be an important complicating factor. In terms of drugs that are used, digoxin, beta blockers, calcium channel blockers are all indicated in certain types of heart failure and are used quite commonly, but generally are not well tolerated in patients with amyloidosis. In terms of vasodilators, especially if proteinuria is a presenting problem, such as a patient with nephrotic syndrome, then you may want to use vasodilators to control the proteinuria, but that may be very difficult in any individual patient. So you have to personalize that treatment. In terms of managing the orthostasis and autonomic dysfunction, that is a common comorbid condition in amyloidosis, midodrine and droxidopa are the best initial therapies. And then the treatment of atrial and ventricular arrhythmias is a very complex topic and has to be individualized. But nonetheless, in almost all patients, you're going to have to struggle with those issues. In terms of the treatment of autonomic dysfunction, it can be extremely challenging. The items that are on the right of this slide, the non-pharmacologic treatments, should probably be done in most, if not all patients, especially if they have significant autonomic dysfunction. And then on the left of this slide are the pharmacologic therapies. For the most part, the top two are the ones that I use, and at times we have to use them in combination. Those include midodrine and droxidopa. In patients that continue to be in sinus rhythm, especially with evidence of heart failure and hypotension, I found that ivabradine, the last one listed there, may be useful, but it does require that they be in sinus rhythm. The other drugs listed are options, but I have not found them to be particularly helpful in these particular patients. In terms of atrial and ventricular arrhythmias, this again is very common and very complex. The most important thing to realize in patients with amyloidosis is that they're at very high risk for intracardiac thrombus and a risk of stroke. So how you manage intracardiac atrial thrombi is a critical element to best patient care. And I would say that if a patient develops atrial fibrillation and you're considering cardioversion, it's pretty much a clinical mandate that you would do a transesophageal echo, because there's no other way to screen for an atrial thrombus without that procedure. New therapies are definitely needed to try to figure out how to manage this best. And then the whole issue of implantable cardioverter defibrillator placement is very controversial and has to be individualized. In conclusion, AL remains uncommon, but not nearly as rare as originally thought. It is absolutely essential to differentiate between AL and ATTR. And it's a crucial piece to make sure to get this proper. In terms of anti-plasma cell treatments, that is the basic point for the treatment of AL. And there are many drugs that have been shown to be of at least some benefit. But at the current time, the most powerful regimen is Dara-Cyborg. It is approved by the FDA in the United States and is awaiting approval in other countries. There are many new therapies in development that may be very attractive. And key is still early diagnosis, because the earlier you start treatment, the better the outcome. So putting it all together, without a doubt, careful attention to volume status is critical. Sodium restriction is absolutely essential. Autonomic dysfunction is a common occurrence and may be difficult to manage, and it will require other medications that you're not particularly used to. Typical medications that are used for heart failure are poorly tolerated. As mentioned, the arrhythmia issues are complex. They're also very common, and the rate of atrial thrombus is unacceptably high and requires special consideration. And without a doubt, specific treatment for AL and ATTR amyloidosis is critical to really treat the underlying disease, and has led to improved outcomes for these patients.
Today, I will be discussing the importance of establishing the correct diagnosis in patients with cardiac amyloidosis. This is meant to be a brief introductory lecture, and you can access the full-length lecture online at the France Foundation website. Now let's dive into the talk. When I think of the diagnostic and management continuum for cardiac amyloidosis, this general process can be broken up into 4 main components. First, there must be initial suspicion for the diagnosis of amyloidosis. And once initial suspicion is raised, we can then proceed to confirm the diagnosis. Once cardiac amyloidosis is diagnosed, however, we must confirm the amyloidosis subtype, and from there, we can then move on to treat amyloidosis. For this current talk, we will focus on this third step, confirming the amyloidosis subtype. Cardiac amyloidosis results in the vast majority of cases from either light chain amyloidosis, abbreviated as AL, or transthyretin amyloidosis, abbreviated as ATTR. AL results when a plasma cell neoplasm produces excess clonal-free light chains, which then misfold and deposit in organ tissue as amyloid fibrils. Conversely, ATTR results when the transthyretin protein dissociates into monomers, which then misfold and aggregate in organ tissue as amyloid fibrils. While the causative disease processes for light chain amyloidosis and transthyretin amyloidosis are very different, clinically, the 2 disease states often present in a very similar fashion. Heart failure is often the primary symptom of disease, and this may coexist with cardiac arrhythmias such as atrial fibrillation and neurological abnormalities such as carpal tunnel syndrome. Similarly, the findings on basic cardiac imaging are essentially identical for AL and ATTR. These findings include increased LV and RV wall thickness, apical sparing pattern of longitudinal strain, and typical findings on cardiac MRI, such as diffuse subendocardial late gadolinium enhancement, increased T1 relaxation times, and increased extracellular volumes. When it comes to diagnostic testing, there are also many similarities between AL and ATTR. On cardiac biopsy, both AL and ATTR cardiac amyloidosis present as waxy, amorphous extracellular deposits that stain positive with Congo red and exhibit apple green birefringence under polarized light. Technetium-labeled bone scintigraphy, such as the pyrophosphate scan, has emerged as a non-invasive diagnostic option for ATTR. However, a small percentage of patients with AL will also have a positive technetium scan. So because of this, additional techniques are needed to clarify the amyloidosis subtype and distinguish between AL and ATTR before selecting a therapeutic pathway. The most important technique available to distinguish between AL and ATTR is mass spectrometry, which should be performed on all tissue specimens that are positive for amyloid by Congo red. Amyloid deposits are first resected from the pathology specimen using laser microdissection, as shown here on this slide for a renal specimen. That amyloid tissue is then entered into a mass spec machine which breaks down the amyloid into individual protein components and allows for proteomic identification of the amyloid fibril. This represents the gold standard for typing of amyloid deposits and overcomes the false positives and false negatives that are associated with immunohistochemical techniques. Now, when a non-invasive approach is used for diagnosis of TTR cardiac amyloidosis, specifically with technetium-labeled bone scintigraphy, a monoclonal protein evaluation is critical to exclude light chain amyloidosis, since light chain amyloidosis is the most common cause of a false positive bone scintigraphy scan. In general, there are 3 tests that must be ordered along with a bone scintigraphy scan in order to exclude AL. These are number 1, serum-free light chain levels, number 2, serum protein electrophoresis or SPEP with immunofixation, and number 3, urine protein electrophoresis or UPEP with immunofixation. This last test does require a 24-hour urine protein. And based on the results of these 3 tests, we can decide how confident we are in the ability of bone scintigraphy to make the diagnosis of ATTR cardiac amyloidosis. So if all 3 of these tests are normal, as shown in the top row of this table on the right, then we can be confident that a grade 2 or 3 scan on bone scintigraphy is diagnostic of transthyretin and cardiac amyloidosis. However, if any of these tests are abnormal, then we're not sure if a positive bone scintigraphy scan represents AL or if it represents ATTR, and tissue biopsy is necessary to make the diagnosis. As shown in the bottom row of this table, there are certain circumstances where the SPEP and UPEP are negative, but the serum-free light chain levels are abnormal, but we're not sure if this is due to a monoclonal gammopathy or if it's due to renal dysfunction. And in this case, clinical correlation is required, and this is usually done in collaboration with a hematologist or oncologist. For patients who have undergone the diagnostic evaluation for cardiac amyloidosis and are confirmed to have transthyretin cardiac amyloidosis, there is a 3rd test that is needed to confirm the amyloid subtype, and that is genetic testing. So as many of you will already know, there are 2 main types of transthyretin amyloidosis: a wild type, which occurs in older individuals, and a hereditary form, which results from a mutation in the transthyretin gene. There are a number of pathogenic TTR mutations that have been identified causing either neurological disease, cardiac disease, or both. And it is important to identify individuals with these genetic mutations because of highly effective treatments that are currently available and approved only for treatment of hereditary transthyretin amyloidosis with polyneuropathy. These 2 therapies are patisiran and inotersen, both of which are gene silencer agents that reduce transthyretin protein production. It is also critical to discuss screening of family members for patients with hereditary transthyretin amyloidosis. In summary, it is very important to confirm the amyloid subtype before proceeding with amyloid treatment, and the specific confirmatory testing required is different depending on the diagnostic modality pursued and the amyloid type. For patients who are diagnosed via tissue biopsy, mass spectrometry should be performed to identify the amyloid fibril type in all samples. For patients who are undergoing bone scintigraphy to diagnose transthyretin cardiac amyloidosis, a monoclonal protein evaluation is critical to exclude light chain amyloidosis. And finally, for patients with transthyretin amyloidosis, genetic testing is critical to identify hereditary transthyretin amyloidosis subtypes, because this will guide therapeutic decision-making as well as screening of family members.